Okay, we're going to look at the comprehensive assessment. We are going to be looking at functional, physical, cognitive, psychological, social, spiritual, and we will, throughout upcoming chapters, I will have further assessments in you, especially for spiritual and the psychological and the cognitive. I have tools available for you within the learning plan to look at. Excellent video on the comprehensive assessment, the roles of different professionals, and the issues related to. Again, as we're assessing the older person, we really have to look much more in depth at their problems. How are they swallowing? How can they see? How can, again, back to health literacy, what do they understand? Can they swallow? Can they express themselves? How is their vision? So really looking head to toe for the normal age-related changes that we experience. We do, again, everything is an individualized plan of care, and by doing that, we really establish a baseline. This is extremely important to know someone's cognitive level. Should their sodium go a little off because maybe they're dehydrated or in fluid volume excess, and that is a sign of a sodium imbalance. So it is imperative to have that baseline so we know as diseases and other things manifest itself, how does that come into play and what is their baseline? Because this is a time we don't within normal limits, because we need to know what their normal limit is. And again, it's all about baseline. So we will look at their ability to self-care, functional analysis, and there's an excellent article I put out there on cats, and also the Lawton Independent ADL checklist. Very quick and very easy to do. So those are available to you, and those are wonderful resources that by answering those questions really starts triggering us for those home needs, additional assistance, and what can we do to keep them functional as possible. We always do a systems approach. So as you're reading and as we're exploring diseases, you will be learning what are normal circulatory, respiratory, GI, GU, functional changes that can happen with aging, what is their baseline, and what disease do they have. Sexual function is still very something you have to be able and comfortable to talk about it. Elderly sexuality is very prevalent, and with the enhancements of drugs nowadays, people are having wonderful sexual lives later. The other thing that we'll explore coming up is you need to have awareness of how large the lesbian, gay, and transgender culture is out there. Neurological function. What is their normal musculoskeletal function? Do they have arthritis? Are they having degenerative joint problems? Rheumatoid arthritis? How do they move? Do they have pain when they move? Sensory function, again, back to that vision and hearing, speech. Their skin function. Skin loses its elasticity. It tears easier. We have to be more sensitive to maybe even the tape that we're doing or how we will touch someone, especially also if they're on like a blood thinner. To understand the endocrine and metabolic function changes that we'll see. Hematology and immune function. We know that as the kidney ages, we don't produce erythropoietin, so the risk for anemia is much higher. As we've mentioned with some of the theories of aging, we lose our ability, the thymus gland is smaller, our infection fighting capacity is diminished. So we really have to just do a more thorough baseline complete assessment and have those good communication skills to be able to get the data that we need. As we do the cognitive assessment, it really does vary. I did put the mini mental out there for you to look at. We will want to know if they have any of the type of dementias or if they have Alzheimer's, because this will really impair our ability to do a complete assessment when we're looking for subjective data from that client, because those that have altered mental status cannot answer these questions correctly. The psychological assessment, we look at quality of life indicators. How do they view successful aging, and are they? The geriatric depression scale, we have a learning plan coming up that covers dementia and depression and delirium. I do have that scale out there, and we'll be discussing the psychological component there. Social assessment, we really want to look, do they have good relationships? Are they very active? I am so blessed again that I have the 76-year-old dad that has a day planner, that has good support systems, a good group of friends. I don't know how that would be if he didn't, because I think he'd never leave the house. It gives him something to do. Your book discusses different assessments available as you're looking at someone's social network, and I did put out a sample of that Lubin social network scale for you on Blackboard. We want to improve things. Some people, it is better for them to live in assisted living because they have someone to talk to, someone to have a meal with, someone to look forward to seeing in the hall than just being alone in a home. Other assessments, we need to look at obesity. We need to look at their ability to cook, their ability to get food. I have elder friends that physically can cook in the kitchen but can't get to the grocery store. So we've worked out a little support system where we make sure one of us gets Mike's grocery list and we pick up whatever he wants, and then he can cook in his home. But because of his mobility issues, he can't function in a grocery store. History of weight changes is a big thing, especially when we're worried about the possibility of a cancer. We want to look also indicators of depression. We'd like to have them give us a 3 to 7 day meal history. And most healthy people, younger people, will say, just give me a diet recall of what your diet was like in the last 24 to 48 hours. We want to look for the week. We want to see that fresh fruits and vegetables are included, good sources of protein, the possibility of maybe needing a lower salt intake, and as needed, we will consult with a nutritionist or a dietitian. There's 10 principles to a comprehensive assessment. It needs to be individualized for the older adult. It has to be individualized to them. It takes into account those age-related changes, age-associated diseases, understanding heredity and lifestyle, and how that can affect that physical change. That we are members of a team. We need all members of the team to help. We are not experts in all the services available in the community, or knowing the best or most appropriate use of adaptive equipment as an occupational therapist may to make those ADLs better, or for functional ability to get the physical therapist involved, the nutritionist. And it is not a neutral process. It is very evolving and it is ongoing. Again, go to that older adult for the information. Only use secondary sources when it is not possible to get that information, and you need to hope that they're good historians and also giving you accurate information, because if the family lives out of town, they don't know that parent on a day-to-day basis. We need to look at what the person can do, not what they can't do. So we always focus on the strengths. Always focus on the strengths, and everything that we were going to do is going to improve or allow that disability more independence. We want to be very task performance and the capacity to do it. Capacity gives you better results. Because if I ask you, do you dress without help? It'll probably be a yes or no answer. Can you tells me about your physical ability. Also, those that have cognitive limitations, you may have to break down things into smaller steps. They can't handle all that information at one time. You may not need to do all the tools at one time. It's going to be look for those resources. I put many out throughout this book. Some are pertinent to an acute care setting. Some are relevant to the nursing home. Some are for home care. So you need to pick the tool for the environment that that person is in. And again, in that comprehensive assessment, we need to look at that person's meaning of health. Okay, how does that affect them? Because our meanings can be very different in how we adapt around that. So again, that comprehensive assessment is essential to geriatric care. We will be doing much more of this as we get into systems. We do need both objective and subjective data. Unfortunately, with cognitive impairment, that subjective data is not available or can't always be construed as accurate. We don't look at just the physical. We also need the psychological, socioeconomic. Do they have the money to even shop for food? And again, their spirituality. And we'll be looking at that coming up later on.